This e-lecture or voiceover will be a review of inflammatory heart conditions found in Chapter 36 of Lewis. Okay, so our learning outcomes. In this lecture, we will discuss the causes, pathology, and manifestations of inflammatory heart disorders. We're going to discuss endocarditis, pericarditis, rheumatic fever, and then myocarditis. We're going to develop a comprehensive plan of care for a patient diagnosed with an inflammatory heart disorder. All right, so endocarditis. So endocarditis, or IE, is an infection of the innermost layer of the heart, which also includes the valves. Risk factors listed for IE are pretty inclusive. I'd be familiar with these. In my practice with caring for open heart patients, the majority of my experience with IE patients surround IV drug use or prior valve placement. It's not surprising in light of the heroin epidemic in Greater Cincinnati. IE can be classified as either subacute or acute. Subacute affects those patients with pre-existing valve disease, and the illness may extend over months. Whereas with acute IE, these patients typically don't have any pre-existing valve disease, and they present as a rapid progressive form of the illness. So the most common organisms that affect IE are staph and strep. These infectious vegetations consist of fibrin, leukocytes, and platelets. So they're going to stick to the surface of the valves of the endocardium. So often these vegetations are going to fragment and circulate throughout the patient's vasculature or vascular system, which is going to be known as systemic embolization. Often IE patients will have nonspecific manifestations such as fever, weakness, and fatigue. As a result, they might delay treatment, especially if they don't have a pre-existing heart or valve condition. I had a patient once who presented to the ER with a 2-week history of nonspecific symptoms. She had had a mitral valve replacement 2 weeks prior at an outlying facility. By the time she got to Good Sam, she was already in septic shock with decompensated heart, renal, and liver failure. So unfortunately, her significant other believed that her nonspecific symptoms were the norm after her heart surgery. Being weak, being fatigued, maybe not wanting to eat a lot. But in reality, those were the kind of nonspecific symptoms of IE, and she was high risk because she had had valve replacement surgery. So please pay careful attention to the vascular manifestations listed on this slide. They are key characteristics of IE. So petechiae, subungual splinter hemorrhages, typically found under the nail beds, Osler's nodes, Janeway lesions. These are going to be purplish red spots that are going to be found on the palms or the soles of your feet, Roth spots, and then any symptoms related to embolization to other various body organs. Like I said, renal failure, liver failure. So this slide just depicts the petechiae that can be found on your arms, your legs, generally anywhere, but this is the most common place you're going to see them, maybe the trunk. And then the Janeway lesions, which are also common with IE. And this black longitudinal streak of the nail bed is called the splinter hemorrhage, and this is very characteristic of somebody who has IE. And this is just another pictogram of endocarditis if you're somebody who likes to, a visual learner who likes to look at and learn from those. So the health history should focus on predisposing risk factors. Most often, blood cultures will be positive in patients with IE. They will also have leukocytosis if you draw a CBC. They're going to have an increased SED rate or ESR and an increased C-reactive protein or CRP, which are both kind of indicative of inflammation. And these, again, are pretty non-specific tests, but I guess in combination with the patient's clinical symptoms or clinical presentation, this might confirm it. The major prognostic criteria for IE includes 2 positive blood cultures 12 hours apart, non-valvular regurgitation, and vegetations noted by echocardiogram. A chest X-ray should be performed to assess for any signs of heart failure, such as cardiomegaly or pulmonary edema. An EKG or continuous ECG monitoring might show some abnormalities in the cardiac conduction system, since the mitral valve lies so close to conduction tissue. And then a heart catheterization or angiogram might be performed to assess valve function and any coronary artery patency if valve surgery replacement is indicated or is needed in the future for this patient. With IE, typically more than one IV antibiotic is ordered at a time, such as Bank or gentamicin. These medications are dose dependent on drug levels and should be monitored per hospital protocol or physician order. Remember, these antibiotics can be nephrotoxic to the kidneys. Therefore, renal function should be monitored closely in accordance with the drug levels. So antipyretics, analgesics are ordered for fever and discomfort. You might do repeat blood cultures a few weeks or a few days after to assess antibiotic effectiveness. Valve surgery is indicated in severe cases of IE. And then additional management is going to include supporting other body systems. And this might include blood pressure support medication, monitoring their heart rate, managing any kind of arrhythmias that may occur because of the infective endocarditis, and managing oxygenation. These patients might need a little oxygen via nasocannula, or if they present in a severe case of IE where they're in sepsis with septic shock, they might need to be intubated and put on the breathing machine or the mechanical ventilator. This slide is a guide to prophylactic treatment for those high-risk patients for IE. This information was taken from and can also be found on table 36-2 on page 783 in the Lewis textbook. Although all the diagnoses are relevant, I feel that impaired tissue perfusion, secondary to the systemic embolization from the vegetations, and decreased cardiac output are probably your priority diagnoses. So pericarditis is the inflammation of the pericardial sac that surrounds the heart. The most common causes of pericarditis are viruses, trauma, and the effects of thoracic surgery and a myocardial infarction. So that's always been my experience with patients who have pericarditis. They've had a myocardial infarction or heart attack, or they've had open heart surgery. And so both of those make sense because, you have that inflammation and edema after that ischemia, infarction, and death of that cardiac tissue. And then with thoracic surgery, manipulation of the heart, that's common sense. After surgery, you're going to have some swelling, fluid accumulation. So these patients are high risk for pericarditis. Inflammation is going to occur between the visceral and parietal layers of the heart or the sac. This space contains very little fluid. So therefore, even very small changes can have significant impact on heart function with pericarditis. The fluid in the space serves to decrease friction between heart contractions. So pericarditis occurs when there is an influx of neutrophils, increased vascularity, and fibrin deposits on the epicardium, which can lead to inflammation. So pericarditis is going to be characterized by progressive, sharp chest pain that is worse on inspiration and with lying down. So these patients, when they sit up or lean forward, their pain is going to be alleviated. So 50% of patients with pericarditis are going to have a pericardial friction rub. And unlike when I told you on Monday when we talked about that S3 sound, how elusive it is, these patients, you can really hear this pericardial friction rub. So if you're somebody that, is, oh, I heard, this is kind of exciting for me, these patients, you're really going to be able to hear it. So the rub is a high-pitching, grating sound that's going to be best heard over the apex of the heart when the patient is leaning forward. Sometimes it's intermittent, kind of comes and goes, but, I didn't find that. I found that if it was there, it was there. So obviously, with problems with that intense pain with breathing in or lying down or with coughing, a lot of these patients then are going to have problems with dyspnea and tachypnea because they're not going to want to breathe fully. And then they might be breathing faster and more shallow to kind of compensate for not being able to take deep breaths. So the two major complications that can result from pericarditis are pericardial effusions and cardiac tamponade. Okay, so this can occur with the buildup of fluid in the pericardial space. Like I said, there's only such a narrow space there, so even very small buildup of fluid can cause problems. And a lot of times it's just going to depend on how quickly the fluid develops. So sometimes patients over a longer period of time, they may have accumulated larger amounts of fluid, but they've been able to compensate for that large volume. Whereas sometimes if the fluid builds up very quickly, you'll see these patients go into tamponade. So as a result, the tamponade is going to result from that infusion that increases, and it's going to constrict the heart. It's going to restrict it. So some manifestations of tamponade are going to include confusion because you're going to have symptoms of low cardiac output. You're going to have muffled heart sounds because that heart's constricted. It can't contract effectively. You're going to have a narrowed pulse pressure. You're going to truly see that JVD because when somebody has pericarditis and they've tamponaded, none of the heart is functioning properly. So you might see both left and right-sided symptoms of failure. So these manifestations are very important as the key characteristics to tamponade. Muffled heart sounds, narrowed pulse pressure, JVD, and a pulsus paradoxus, which is a decrease in systolic BP during inspiration. So this slide just portrays an image of the difference between a normal pericardial sac and an inflamed pericardial sac. And that's just a representation of JVD, or jugular venous distension. So in a patient with pericarditis, you will most likely see ECG changes such as ST elevation, and this is going to directly correspond to the abnormal cardiac repolarization secondary to that pericardial edema and inflammation. So an echocardiogram is useful in evaluating a pericardial effusion or cardiac tamponade, but it may not be your number one in just diagnosing mild pericarditis. Chest x-rays are typically normal, but can also show cardiomegaly if a large pericardial infusion is present. So common lab testing might include a CBC for their white count, especially if this is infectious in etiology. Again, your CRP, your SED rate for inflammation, and then cardiac enzymes, if it's relative to a myocardial infarction, or if the low output is enough to further cause ischemia infarction. So in combination with a good health history, These lab findings can help determine the etiology of pericarditis. All right, so treatment for pericarditis should be targeted as much as possible to the underlying cause or etiology. So we're going to treat the underlying problems and symptoms. In patients with an identified cause other than viral infections, specific therapy is going to be appropriate to the underlying disorder as indicated. In the treatment of pericarditis, the goals of therapy are going to be the relief of pain. We talked about that sharp inspiratory pain. Resolution of the inflammation or edema, and if present, pericardial effusion, and to kind of support that patient who's got the possible tamponade. So the use of NSAIDs for all patients with pericarditis is recommended as first-line treatment. The duration of therapy is based upon the presence of symptoms, which is usually for 2 weeks or less. Common NSAIDs used to treat pericarditis include ibuprofen, aspirin, and NSAID. Nursing implications with these medications include monitoring for gastrointestinal distress and bleeding, especially if used concurrently with anticoagulants such as Coumadin. The majority of patients have prompt resolution of symptoms without recurrent pericarditis when treated with NSAIDs alone. However, when used as an adjunct or an adjuvant to NSAID therapy, colchicine can reduce symptoms. It decreases the rate of recurrent pericarditis and is generally well tolerated by patients, not very many symptoms. And I think most of us are familiar with colchicine being used with gout. So steroids such as prednisone are used only if patients are non-responsive to NSAIDs or there's a contraindication to using them. Other reasons might include if a patient's inflammation is secondary to an autoimmune disease, such as lupus. So, for example, when I took care of a lot of these post-op open heart patients and they'd have pericarditis, unfortunately, utilizing ibuprofen and Indocin after open heart was kind of contraindicated because we were concerned about their bleeding risk. We were concerned about kidney function after surgery. So a lot of times we would use a short course of like a steroid dose pack on some of these patients because we knew what the pericarditis was from, and we knew that after several days the inflammation would come down and they would be okay. So for them, the steroids were indicated, but just for that first-line treatment for pericarditis is going to be your NSAIDs. So most patients with acute pericarditis can be managed effectively with medication alone. On occasion, some patients are going to require more invasive therapies. So catheter drainage of a pericardial infusion is an effective means of reducing fluid accumulation and preventing fluid reaccumulation. So indications for a pericardiocentesis or pericardial drainage includes patients with cardiac tamponade, if there's a purulent pericarditis or a suspected neoplasm. So prior to drainage, patients may need to have their hemodynamics supported if they're in tamponade. So we might use volume to enhance their preload, and we might use inotropes to increase their contractility. Now, I know we talked about digoxin, but digoxin wouldn't necessarily be used with these patients. We're talking about like IV inotropes, like dopamine or dobutamine. So again, working on their preload and their contractility in an effort to maintain their cardiac output. So complications, though, from doing a pericardiocentesis or pericardial drain are going to include dysrhythmias, possible pneumothorax, and or a myocardial laceration. So a pericardial windowing can be achieved either by traditional heart surgery or video-assisted thoracoscopy, thoracoscopy, or VAT. So again, this is not typically going to be your first line treatment. These are for patients who have had persistent pericarditis or maybe pericardial infusions that have been resistant to treatment. So these techniques may result in a lower incidence of infusion reoccurrence compared with pericardiocentesis and prolonged catheter drainage. However, surgical experiences are not always concordant, and the efficiency of the window remains largely unproven in trials. All right, so pericarditis and nursing diagnoses. So obviously acute pain, risk for decreased cardiac output. Like we said, with our pain, we're typically going to be using more of the NSAIDs versus narcotics. Narcotics is way at the back there. We're not going to be using those at the forefront. But if their pain's not controlled, we may have to add a little something to that. Okay. So a lot of times in the beginning of pericarditis, we might keep these patients on bed rest. We're going to keep their head of the bed up, and we're going to position them for comfort. Like we said, leaning forward is going to be more comfortable to them than leaning back. Okay. With the NSAIDs, we're going to monitor for any signs of bleeding, gastrointestinal distress. So we're going to make sure maybe they take these things with food. And like we talked about with the pain and kind of the difficulty breathing with the pain when you take those deep breaths in, we're going to be monitoring their breathing pattern and their respiratory status. So utilizing oxygen as needed, working on kind of the incentive spirometer, maybe deep breathing and coughing, splinting the chest with those things. All right. So myocarditis is an inflammatory disease in the myocardium with a wide range of clinical presentations from vague to extreme. So myocarditis is typically caused by a wide variety of infectious organisms, autoimmune disorders, and exogenous agents with a genetic and environmental predisposition. The myocarditis usually manifests in otherwise healthy people and can result in rapidly progressive heart failure and arrhythmias, just like we saw in the case study that you looked at on Monday. So patients with myocarditis have a clinical history of acute decompensation of heart failure, but they can have no other underlying cardiac dysfunction or have low cardiac risk. So I think the case study that we looked at, the man was 43 and had had no other symptoms other than like signs of an upper respiratory tract infection with very vague symptoms. So patients with myocarditis may present with the following signs and symptoms. They might have a little bit of chest discomfort, fever, sweats, chills, and dyspnea. So sometimes if someone presents and we suspect that the myocarditis is related to a virus, they might have had this less than 1 week history of flu-like symptoms, the fever, the arthralgias, malaise, or even like the pharyngitis or the tonsillitis, all which indicate like an upper respiratory tract infection. Other symptoms that might show if the disease is fairly advanced and severe, they might show signs of heart failure, maybe some palpitations, syncope, or even sudden cardiac death due to some of these ventricular arrhythmias that are associated with the advanced heart failure. And I think the case study that we looked at on Monday, this patient had myocarditis, which had advanced very quickly to dilated cardiomyopathy and decompensated heart failure. And so with those patients, they might have a really low ejection fraction at like 10 or 15%, and they're very much high risk for ventricular arrhythmias like VTAC and ventricular fibrillation. So when the myocardium becomes infected, the causative agent invades the myocytes and causes cellular damage and necrosis. I think that's what these arrows are pointing to. Okay, so the diagnosis of acute myocarditis is usually presumptive based on the patient's clinical course and history. So because many cases of myocarditis are not obvious, a high degree of suspicion is required. So some laboratory studies that we might look at to either rule in or rule out myocarditis might include like a CBC count, again, to look at their white blood cell count, a SED rate, a CRP, again, to assess for inflammation. We might look at rheumatologic screening if we suspect lupus or something of that nature, or maybe another autoimmune etiology. We might look at cardiac enzyme levels, and we might look at an EKG to monitor for any arrhythmias. And so some of the imaging study that we may look at might be an echocardiogram, and that might be done to exclude other causes of heart failure or to evaluate the degree of cardiac function, to look at their septum, to look at their wall function, and also to measure their ejection fraction. So angiogram or a heart cath, we might do this to rule out an MI or coronary ischemia as the reason for this presentation or heart failure. And then really remember this, for myocarditis, an endomyocardial biopsy is the gold standard for diagnosing myocarditis. So this allows for histologic confirmation of myocarditis. A biopsy should be done within the first 6 weeks of illness, is the most diagnostic. So during this period is which you're going to see lymphocytic infiltration and myocyte damage are present. So other the collaborative care, it's going to be to support their symptoms. And then if this is a severe case and it's progressed to the dilated cardiomyopathy, then we're going to be monitoring them signs and treating them for heart failure. So and that may encompass all those things we talked about on Monday and the medication sheet you got. So the ACE, the vasodilators, the diuretics, the inotropes, and the beta blockers. Again, supportive therapy, oxygen, bed rest, restricting activity. And if this is an autoimmune disease, are we going to be treating them with immunosuppressants? And then what are the risks with immunosuppressants? Infections. And then anticoagulants. So I know the case study we looked at Monday, he also presented with atrial fibrillation, and we know with how atrial fibrillation works with the atria quivering and the ventricles working normally, these patients are at risk for stasis through your chambers, so it puts them more at risk for blood clots. So these patients might be on Coumadin or warfarin, so you need to think about what are the implications of taking care of somebody on warfarin, and what labs findings would we look at to monitor those levels. And then if these patients progress very quickly or at the end stages of heart failure, do they need an ICD to protect them from ventricular arrhythmias? Do they need a VAD to transplant or to bridge them to transplant? So what's our overall plan for this patient? And is it feasible that these treatments occur? So one thing about myocarditis that I do want you to remember, and it does say this in the book, and I've kind of seen some questions on it, is that most patients, because they've had no underlying cardiac history, obviously, this comes as a big surprise to them. So there's a lot of anxiety and unknown with this. Most cases of myocarditis spontaneously resolve. So there's no maybe lasting damage, or it doesn't advance to those severe cases. So make sure that you know that most cases of myocarditis will resolve. Let's see. So just like we talked about before, decreased cardiac output if things have gotten to that point, maybe pain, anxiety, just like we talked about, fatigue. All right, so rheumatic fever, rheumatic heart disease. So acute rheumatic fever, or ARF, is an autoimmune inflammatory process that develops as a sequela of a streptococcal infection, usually strep A. ARF is characterized by non-suppurative inflammatory lesions of the joints, heart, subcutaneous tissue, and central nervous system. So ARF has extremely variable manifestations and remains a clinical syndrome for which no specific diagnostic test exists. So people who have experienced an episode of ARF are predisposed to reoccurrence following subsequent streptococcal infections. The most significant complication of ARF is rheumatic heart disease, which usually occurs after repeated bouts of ARF. The mitral and aortic valves are most commonly affected. Cardiac lesions and valve deformities occur secondary to this autoimmune response. The incidence of ARF in rheumatic heart disease has lessened since the use of antibiotics, but still remains an important public health issue in more developing countries that are underdeveloped. The rheumatic fever manifests as various signs and symptoms that may occur alone or in various combinations. So the arthritis of ARF is usually symmetrical and involved in large joints in many joints, such as the knees, ankles, elbows, and wrists. The evolution in individual joints tend to overlap, therefore multiple joints may be inflamed simultaneously. So in most instances, the entire bout of polyarthritis subsides within 4 weeks without any long-lasting damage. So severe inflammation from this autoimmune reaction can cause carditis. So patients may present in heart failure, maybe with shortness of breath, dyspnea on exertion, cough, orthopnea, chest pain. Or sometimes it might be very mild, and so they may be asymptomatic, but it still could be auscultated, diagnosed by auscultation or echocardiogram. Some of the CNS syndrome or manifestations, symptomachoria may occur with other symptoms or as an isolated finding. So it usually presents maybe 1 to 6 months after the precipitating strep A infection, and then there are both neurologic and physiological features. So the inability to concentrate, the clumsiness, the involuntary muscle spasms. All right, so just some images that are going to depict the erythema on the trunk and there's some of those subcutaneous nodules that are pretty indicative of rheumatic fever in combination with some of those other symptoms. All right. So the goals of RF and RHD is to eradicate the infection or to decrease the length of the infection, reduce or prevent the inflammatory process, and then manage those long-term effects in subsequent heart failure. So according to the Jones criteria, you must have 2 major and 1 minor finding of of rheumatic heart failure. Or 2 minor findings and evidence of a preceding strep A infection. So the major findings include the ones that we just discussed on the prior slide, and then some minor findings might include fever, vague laboratory findings such as your elevated SED rate or CRP. So some of your major findings, like we said, are the erythema on the trunk, the subcutaneous nodules, the carditis. So those are more of your major signs. So whereas your minor signs, like I said, are the fever, those very non-specific laboratory results. So some things that we need to consider, I think, from a nursing perspective is these patients are going to be treated with penicillin. Obviously, if there's an allergy to that, there's going to be other options. So our role in that, is going to be talking to our patients if they go home on antibiotics, that they need to finish them, that they can't stop early, that they need to be monitoring for any types of allergic reactions with these medications. And then talking to them about pain relief and fever reduction. And then also if this progresses to heart disease, a prolonged heart disease, we're going to talk to them about managing and preventing recurrent bouts of the heart failure. Okay. And then this is just a fun slide that kind of depicts that Jones criteria. So 2 major, and then 1 minor, and then 2 minor with an evidence of recent group A strep infection. All right, so collaborative care. So some of these nursing diagnoses with rheumatic fever, rheumatic heart disease. So some other diagnoses that aren't on here. So what about our risk for decreased cardiac output? Or even how about risk for injury secondary to some of those possible CNS manifestations we talked about with the chorea? And then I guess depending on how severe, the joint inflammation is, and if we're having a lot of pain, what about impaired mobility with some of the severe joint involvement?